Good afternoon. Welcome to the CSG Health Policy webinar today. Our title today is Value Over Volume, Paying for Quality. My name is Deborah Miller. I'm the Director of Health Policy at CSG National Headquarters, Lexington, Kentucky. I hope most of you all are having as beautiful a day as we are here in Kentucky in our early spring. Let me go over a couple of housekeeping details for the webinar. As the announcement said, you are in listen-only mode. You can type in questions at any time during the presentation in the GoToMeeting box that should appear on your screen, and we'll get to as many of those questions as we have time for at the end of the presentation. We will be posting the webinar audio and the slides on our CSG Knowledge Center probably tomorrow. And as an attendee today, you will get notice of the link for that audio and slides. If you want to pass it on to other people, feel free to do so. And we'll get started. Our speaker today is Dr. Ellen Andrews. She coordinates the Multi-State Health Policy Steering Committee for CSG East, one of our 4 regions, and serves on more than a dozen different state, regional, and local health-making councils. She's also Executive Director of the Connecticut Health Policy Project. She's going to discuss with us today state policies and how they can support payment reform, how state governments can partner with other healthcare providers in moving forward on payment reform, what opportunities are provided in the Affordable Care Act for states to tackle this system change. She's also going to share with us some examples of payment reform at the state level, as well as some successful federal Medicare initiatives. And I think we're ready to start, so we'll pass it on to Ellen.
Well, thank you very much, Deb, and thank everybody for listening in. This project was the outgrowth of a grant we got 2 years ago at ERC, where policymakers were very concerned that costs were out of control and quality was not what it should be, and came together to talk about looking at other states and seeing what people were doing that was working. So we had interviews with states that were further along and, first adopters. We got advice from those first adopters. We explored the options and tried to separate, the shiny new policy toy from what was actually working. And we found a continuum, and I'll talk about that. And we developed some guiding principles for states to think about when they're trying to implement one of these things, so or more than one of these strategies. So I will start through them. If I can have the next slide. Probably it won't come as a shock to anyone on this call, but healthcare costs are going out of control, and they're outstripping state budgets' capacity to be able to handle the costs of rising healthcare. The next slide shows that, unfortunately, the future doesn't look great. That blue line is GDP. That's our economy's growth, expected growth into the future. This is CMS, and both the green and the red lines are national health expenditures expected into the future. And you can see there's a significant gap in the annual growth rate between those two. The next slide shows whether we're actually getting anything for all that spending. The light blue line that's very difficult to see is life expectancy at birth among different countries in the OECD. The dark blue line that's jumping all over the place is how much people are spending per person, and that one way over on the side where we're spending so much, that's the United States. So we're not getting more years of life out of what we're spending, and I could take up a lot of time talking about the other parameters of quality, but we're really not getting what we pay for. The next slide is one that I put in. It's from RAND, and shows that there are differences by age, by sex, by race, by education, and by income, but the biggest gap is that big white band over on the side is the fact that all of us aren't getting as much recommended care as we should be getting, and we're paying far too much for it. So that was probably an easy sell, is that we're paying too much and we're not getting what we're paying for. So the next slide talks about the quality question. Only 39% of American adults are confident. This is no secret to the American public. 39% are confident that they can get safe, effective care when they need it. That means that 61% are not sure. Americans only get 55% of recommended care, and 1 in 3 Americans reports getting unnecessary care or duplicate tests. So that's, again, not surprising. The next slide shows that this is for Medicare reimbursements, and it's a little complicated to see, but it comes from the Commonwealth Fund. But if you look at the y-axis is Medicare reimbursement per enrollee, and on the bottom of the first one is Medicare readmissions after 30 days. And as you pay more, you get more readmissions. The second slide shows that as reimbursement goes up, so do hospital admissions for ambulatory care sensitive conditions. This basically means admitted to the hospital for something, a condition where if you got good outside preventive care, you probably wouldn't have had to have that admission. So we're paying a lot for less good care. And I'm going to make the case on the next slide that part of the reason for that is the current incentives that are built into the way we've built our healthcare system. Right now, we pay the same rate for high and low quality services. There's no merit boost. Consumers have virtually no information and no incentive to choose higher quality or higher efficiency services or providers. This drives overuse and misuse of services, especially when people don't know what is misuse. You're obviously not going to be able to make better spending choices, and that higher spending is not correlated with quality, and it's also not correlated with better patient satisfaction. As a matter of fact, a lot of studies coming out of the Dartmouth Atlas project have found that in areas where there is higher spending in Medicare, patient satisfaction is actually lower. So we are not, and we also sent up conflicting incentives between doctors and hospitals and clinics and other sorts of systems, and we should really be trying to coordinate care and get everybody on the same page. And on the next slide, I talk about fee-for-service is one of the reasons that that this system is built and driving this way. When you pay more for every service, for people to make more money, they're going to deliver more services. And so fee-for-service encourages more services, less coordination because you don't pay for coordination. And while that would drive down services, it would obviously drive down revenue. There are incentives for duplication. I mean, how many of us been to the doctor, you know, he says, I can't find it, the test result, let's just do it again just to be safe. So there are incentives to actually duplicate things. There are very few incentives to prevent care. If you get paid to treat problems, you don't get an incentive to prevent problems. It stifles innovation. We also only pay for some kinds of services, generally face-to-face treatment. We don't pay for email, we don't pay for group visits, we don't pay for phone calls, we don't pay for information on websites. Those all have a cost, and they can actually add a great deal to the quality of our care, but there's no reimbursement for that. There's no link to quality. And there is also incentives to increase high-profit services and high-profit patients to cherry-pick and to avoid low-profit. Now, that's not to say that every provider does all these things. Of course they don't. But those are the incentives that are baked into the economics of how we run it. On the next slide, we talk about quality-based purchasing has a very different set of incentives. When you reward better outcomes, you pay more for higher quality care, you get payments are then based on value, which is quality balanced with costs, not on just driving up volume. Quality-based purchasing has to be data-driven. We need data to understand what is quality. It removes incentives for more services, and I'll describe some of the mechanisms to do that. Rewards providing the right services to the right patient at the right time in the most effective setting, which is what I think we would all agree is higher quality care. It provides flexibility for providers to customize care. If there's some people who need a face-to-face, then they can bring them back in. But if somebody else is, a busy working mom and isn't going to be able to come in for that, maybe they can keep track of a condition by phone or remotely in other ways. It rewards patient satisfaction, and I'll talk a little about that. It removes fragmentation and conflicting incentives. the system now has a reason to make sure that a test is only done once. It aligns provider, payer, and consumer incentives to all reward quality, effectiveness, and efficiency. On the next slide, there's a little bit about consumers from a Commonwealth Fund study showing that consumers want quality-based purchasing. This is not a hard sell to voters. 96% of Americans feel it's important to have information about the quality of care that's provided by different doctors and hospitals. 89% feel it's important that they have information about the costs of care to them before they actually get the care. A remarkable concept. And 85% want public and private payers to reward high-quality doctors and hospitals. So having said that, it all should be really easy, right? The next slide is why this should be important to states. This was very important in our policymaking group. State policymakers always want to do the right thing, but they also understand that they only have their piece of the pie. They have, you know, the state can do what the state can do. And but when you actually look into it, the state actually has a huge reach, especially in healthcare. State employee groups are usually one of the largest groups in a state, often the biggest, and 42 states self-insure. So if they invest in saving money, the state bottom line is improved. Medicaid programs now cover 1 in 5 Americans. States regulate insurers, they license providers, they decide in many states through certificate of need what services are going to be available. States also serve as a trusted source for consumer education, for data collection and research in ways that no other institution really in a state can do that. The public health collaborations are huge. States invest a great deal of money in wellness, tobacco control, obesity prevention that benefit everyone, and those are very important quality initiatives. And they need to be integrated into payment mechanisms and require the collaboration of plans and providers, public health groups, and the grantees, because the state spends a lot of money on these programs, but the savings then go to employers and payers, and that should be reflected in the system. States are innovators in medical home, health IT, coverage programs. States have really taken the lead on a lot of these issues. States this is often overlooked, but in terms of workforce, provider training, most nurses in this country are trained in public institutions, promoting primary care, creating an emphasis on accountability and transparency. The other thing that the state can do is they can get everybody in a room. People who wouldn't normally sit around a table without spitting each other will come because state policymakers tell them they have to. And that's also an incredibly powerful position. The next slide, I talk about sort of the options to do this. And I don't want to make this sound too easy. It really isn't. This is all painful, hard stuff. It doesn't happen overnight. And so you should keep that in mind as I go through these. But these are some of the options that states have looked at. And it goes along a continuum from never events. Almost all states now are not paying for never events, things like surgery on the wrong body part, serious drug interactions, incompatible blood transfusions, pressure ulcers, using stitches that should be on the outside of the body, inside the body. Medicare started a list of never events that they would stop paying for in 2008 in September, and they've kept adding to the list. And most large payers as well have a list of never events that they will not pay for. Transparency, that's public reporting, report cards, just letting people know about some of that quality information that we talked about that people don't have, just letting people know who's doing a good job and who's not. Pay for performance, P4P, has been around quite a while. That is where you pay providers more if they are providing care in certain parameters, if they're doing more cholesterol testing, and I'll talk a lot about that. That's very common. The market share option is, I call it tier and steer. That's paying more for quality providers, so you know, if you go to a high-quality provider, you would have a lower copay, for instance, or you would have, I wouldn't count towards your deductible maybe, or just saying, you know, we're only going to put high-quality, high-efficiency providers in our panels, period. You can provide incentives by forgiving copays. You can decide whether people can go in or out of network based, not just on cost, but also quality. Leapfrog is a big private-public partner in this. You can do selective contracting. I talked about that. The next one, shared savings, I'll talk about that, and that is where providers actually get to keep some of the savings that they generate by providing better quality care. Now, there are usually quality standards to make sure that there aren't incentives to just deny care, and there's a lot of it. There are many programs in the Affordable Care Act around shared savings, and we'll talk about some of those and some of the programs that have happened and what's been the outcome. Episodes of care and bundled payments, that's another move up the ladder of payment reform, and that's been tried in several places as well as Medicare. And that I'll talk about more. And then global capitation, sort of the mother of all payment reform, where you pay based on a patient's risk. It's risk adjusted, and you pay so much per year to a network of providers to care for them. 20% of commercial payments now in Massachusetts are under a global capitation environment or a system, and we'll talk about there's some evidence, early evidence on the first year of that program and whether it's saving money. So the next slide talks about transparency. This is one people kind of tend to gloss over, but I think you should really think about it. First of all, it's hard to argue with. Just providing data reporting, you can get definitionals. Definitions are kind of a challenge. Some of that's been worked out through HEDIS, and NCQA has some standardized reporting definitions. Report cards are evolving. There's some mixed results about whether people use them. This month's Health Affairs issue, if any of you are policy geeks, has several articles on report cards, some of which work really well and some of it not so much. We're getting better over time on figuring out how to effectively convey information so that consumers can use it, that payers can use it, and another piece I'll sort of jump to is that providers use it. I am, in another part of my life, I guess my day job, I teach medical students and nursing students as well, and they can be very competitive. And so it is not a bad thing to put a report card out there. Providers get very competitive with each other, and it can be incredibly motivating, even if it's not linked to any economic incentives. Just everybody wants to be the best. Everybody wants to do a good job, and it can be a very strong motivator. State employees and Medicaid programs can use them in contracting, and you can do it in coalitions with other payers. So you can get all payer data aggregation, which is a very big issue now for a lot of things. But if you can get that aggregation, you can do a report card that's general and across populations, which is really helpful. And I guess on the next slide, I talk about P4P, or pay for performance. This is very widespread, but the results are kind of mixed. Some of them work very well and some not so much. There are different ways of deciding what it is you're going to pay for. There are process measures and outcome measures. Process measures are something more like, do you take a patient's blood pressure every year? Outcome measures would be, are you helping them control their blood pressure every year? And obviously, we'd rather pay for outcomes because just taking somebody's blood pressure doesn't make them any healthier. But it is a lot harder to measure, and it's providers prefer the process measures because they can control them. They can send somebody to a specialist, but they can't make them go. They can tell them they need to lose weight, but they can't make them do it. They can tell them to stop smoking. It doesn't make them do it. And so there's a feeling among providers that it's somewhat unfair to judge them based on things that are outside their control, and there's something to that. It's easier to measure, but it's also sensitive to provide a report. Did you really counsel somebody to quit smoking? But outcomes are really what we're looking for. We want people to be healthier, so there is a movement toward trying to pay for outcome measures. Pay for performance is usually meant to improve quality, not to reduce costs, but it can be linked to that. There's also whether you pay for benchmarks. You say there's a certain standard, and we're going to pay for, if 20% of your patients have their hemoglobins, or your diabetic patients have hemoglobins are controlled, then you will get a certain amount. Or do you want to pay for improvement? then you might be paying somebody, a group lower, that's at a lower level of performance, more money, but that's to incentivize them to come up. And you have to, that's a policy decision that policymakers need to make. I'll talk more about Medicaid, but it's being used right now in 28 states, at least 28. That was several years ago. You do need generally permission from CMS to do pay for performance to incentive payments in risk-based systems. You can either target health plans, so if you're in a capitated environment, you can still do it on the health plans, or you can do it on providers. You want to be careful in the outcomes versus process conversation to be sure that you're not teaching to the test. There was a study last year in the New England Journal of Medicine that showed that what is measured and rewarded gets better. So you're not going to test everything. And whatever indicators that you're looking at tend to go up under a P4P program. Others sometimes drop. And then as you shift to those others, the other comes back. That doesn't necessarily mean that P4P had a negative or no impact. Those kinds of things may have been happening anyway. You just have to be very careful when you design them, and you need to measure more than just what you're paying for. There's provider resistance and low Medicaid participation rates in pay for performance. Part of that is that you have to make sure that the payments are salient, that they're big enough to get their attention. That's especially difficult. If they're only getting paid a quarter for, per patient for something that takes a great deal of their time, that's not a big enough incentive for them to do it. The other issue with Medicaid is that many providers, regardless of whether it's true or not, many feel that they're being underpaid, and they may just see these payments as a down payment on what they should be getting anyway, and they may not attach it to the actual performance they're getting paid for. You want to also, as much as possible, coordinate that with other payers, because while there are some providers who only see Medicaid patients, there are many more who have a mixed panel. And if they're getting paid a quarter over here for asthma and 16 cents over here for diabetes, it's just too scattered for them, especially in small practices, to really coordinate and respond to. So that's pay for performance. The next slide shows something about bundled payments, which can also be called episodes or buckets of care. Those are other terms for it. And you basically pay one payment for a full range of services that are associated with a specific event, something like a knee replacement. And now, so that covers everything. That covers inpatient, covers outpatient, covers rehab, might cover labs, home health. And that places the providers at financial risk. If they don't do a good job of making sure that you stay well and you come back into the hospital after a knee replacement surgery or some other surgery, then it's on them. They're not going to get paid any more for it. They've been paid the bundle for the amount. So they have an incentive to keep you well. It's common now for physicians in general surgery and obstetrics, and it's very similar to DRGs and Medicare, which I apparently thought was so important that I wrote it twice on the slide. I apologize. And there are pilots for Medicare and Medicaid for bundled payments in the Affordable Care Act. The next slide talks about shared savings, which is taking it up a notch. That allows providers to share some part of the reductions in cost per total patient, not just for the knee replacement, but for the entire year. This gives them an incentive to not only keep you out of the hospital once you're in, but to keep you out of the hospital in the first place, to keep you from needing knee replacement surgery or some other surgery. To avoid incentives to deny care, which is what people were concerned about capitation over managed care years, so you tie it to quality standards and they have to meet a certain quality level. Medicare had a very large demonstration of shared savings. It took 5 years to implement with 10 fairly sophisticated groups, places like the Mayo Clinic. The quality improvements were very good. However, it did not reach the expected savings targets. The savings threshold was 2% at least, and that was just to weed out sort of structural fluctuations. The savings threshold, there was also a great deal of variation between sites and how much savings they got. But the Affordable Care Act, and so they're working on refining that technique, but the Affordable Care Act includes many more opportunities for Medicare and Medicaid shared savings. The next one is the last option, the sort of the mother of all options is global payment rates. On the next, great, thank you. Massachusetts is a leader in this. 20% of their commercial payments are under global payment rates right now. Blue Cross Blue Shield is the main sponsor of these kinds of plans. They pay one risk-adjusted rate for each patient to cover all their care, in and outpatient, long-term care, rehab, drugs, everything. They link it to pay for performance to ensure quality of care, and that can be up to 10% of the total budget to a provider, so it's a lot of money. In the first year, they got some mixed results. Quality was up for some measures, not for others. All groups met their savings targets and received rewards, but the savings from reduced prices did not increase equal the total amount in bonuses that were paid out. There was a shift to outpatient care. They reduced prices, but they did not actually reduce utilization. So they're still working on tweaking that. So that's, that's definitely cutting edge sort of payment reform. I'm going to just go very quickly through the next supportive options. Patient-centered medical homes, which we could spend another hour talking about, but those are clearly, that's delivery reform, but it supports quality care and paying for quality. Accountable care organizations, and I'll talk real quickly about that in a few minutes. Electronic medical records and health information exchange, wellness programs with employee supports and rewards can definitely increase quality care. Workforce development, we're going to have to make sure that we have enough, especially primary care providers, to provide this quality care. And comparative effectiveness research, which is one of my soapboxes, is actually figuring out what's quality and what's not. We need to do a lot more, but there's $1.1 billion in the Recovery Act and more money in the Affordable Care Act for that kind of research. I think we can skip the next slide, patient-centered medical homes. About half of Americans report very poor coordination of care, and we need more patient-centered medical homes. Accountable care organizations, this was created in the Affordable Care Act. Well, it was actually created by researchers at Dartmouth, but they're networks of providers who are collectively rewarded to slow cost growth for their patients while improving quality of care, generally through a shared savings model. There's a lot of interest in that and support for that in the Affordable Care Act. We can switch to comparative effectiveness research, which is something also supported by the federal government. So new treatments and drugs and devices, procedures are the largest driver of rising healthcare costs. That's not me saying that, that's GAO. But there's very little information, unfortunately, on which ones are worth the expense over current care, and also best practices within treatment. Even the research that's available takes many years to enter practice, patterns of practice. So there are large federal investments in research. One thing here we're doing in New England is CPAC, which I'm on the board, but I can't remember what CPAC stands for. But it's a collaborative of clinicians, researchers, and patient advocates doing a very deep dive into comparative effectiveness research. We get it from the Agency for Healthcare Research and Quality, from HHS, and we vote after a very deep dive. It is mind-numbing stuff. But we vote on whether the evidence is sufficient to recommend treatments. And in our last meeting, we talked about treatments for treatment-resistant depression, and we came up with a vote on a fairly new treatment. And because of that, Medicare in our area has decided to change their policies and is now covering that because it was found to be comparatively cost-effective. The next page, the next slide, talks about federal payment reform, which is a very strong feature in national reforms I talked about. There's an innovation center and waivers, new waivers, ACOs, the Accountable Care Organizations, Comparative Effectiveness Research, Medicare and Medicaid bundled payments. In Medicare, there are 23 programs right now for trying out, piloting different ideas of payment reform. There was a premier demonstration, a hospital P4P program. Payments were based on conditions and competition. This was over a decade, and they found a 10 to 17% of improvement was due to the incentive program. So there was mixed results on that as well. But over 500 small physician practices got performance bonuses that averaged $18,000, and some went up as high as $62,000. And they have some very good quality improvements to report out of those programs. So those are ongoing and actually have been strengthened. The next slide shows Medicaid payment reform. This is what's happening in other states. Most states risk adjust their managed care capitation rates, and 22 adjust it for health status. 19 states include pay for performance in their health plan payments. They have withholds, bonuses, enhanced rates, shared savings, auto assignment, data reporting incentives, and performance pools where a certain amount of the capitation rates are withheld in a pool and then apportioned back to plans based on quality reports. Pennsylvania, Texas, Idaho has an interesting PCCM program where they are piloting management of people with diabetes under a pay-for-performance arrangement with their FQHCs, which is showing some promise. 3/4 of states with managed care plans publicly report on their quality, and some report on provider quality, and 16 states are assessing quality in their fee-for-service system. And I'll talk a little about, just because I'm from the eastern region, I'm going to talk about 2 states in our region. The first one is Maine. Maine's doing some fascinating. They were truly an early adopter. In 2005, they adopted a strategy. It was a multi-payer collaborative, the Maine Health Management Coalition, but with the leadership of the state employee plan. They had a strategy to encourage consumers to make informed choices. This was a steer and tier. They started out with a number of blue ribbons. They've now gone to good, better, best. But if you go to their website, you can plug in, a city and see which providers in different areas are providing better care, and you have incentives to go to them. I urge you all to go to www.getbettermaine.org. And it's hospitals and physicians. They've been expanding this every year. And this year they're now expecting flat funding for their state employee plan, which, how many states wouldn't love to have that? They engaged providers in the development of those standards and the quality improvement plans. They did a lot of messaging to members that was web-based, and they became a trusted source of information. And in the first year, employees with diabetes, they found the costs were $1,300 less. And they are now transitioning to bundled payments. On the next page is Vermont, which is doing a single payer reform. They are going to set global budgets for healthcare costs for all of their providers and new payment models. They are guaranteeing coverage to residents that is not linked to their employment. There will be a single system of provider payments and administrative rules, which will just remove a whole lot of headaches for a lot of providers. The healthcare system, however, will remain privately owned. Doctors will not work for the state. Payment reform is to link payment to quality, and they're working very hard on their medical home initiatives. They're their blueprint for health, workforce development. They have health IT to die for. They expect to save about $500 million a year and to have it operating in 2017, which kind of takes my breath away, but having been to Burlington, I believe they can do it. And they are planning this all through the Green Mountain Care Board, which has been set up and is now working very hard. And they have authority to set rates, control certificate of need, review insurance rates, and hospital budgets. I think I'll just leave you with the next slide is the lessons from some of these states where people are really ahead of the curve. And if I'm hoping that you all be embarking on payment reform, and if you do, this is what we learned from them around sort of how to make it happen and herd the cats, essentially, because this is all really hard stuff. Start with collaborating. Listen a lot. Go slowly. You may feel that the crisis is upon you and it's getting worse, but you need to take the time to do this right. You shouldn't sneak anything over on anybody. Start small and start with the strongest partners. Don't necessarily start with the biggest problem because you want to have success. It's really hard to do these, and you want someone who's a strong partner to work through the bugs in the system. You want a very fair and open process so that everybody understands when they're getting paid more or they're getting paid less, why. Everyone on the same page and everyone has the same understanding of definitions and terms. Be very clear on your goals and be very single-minded in your dedication to those goals. Do not get pulled off into the weeds. There needs to be a very strong consumer education piece so that people understand that this is about boosting quality. This isn't just about denying them something. This is about better health care. You need to plan for transitions, those winners and losers. Don't underestimate the power of disclosure and transparency. That can often be a stronger motivator than money. As I said, providers are very competitive. And you need to be brave. You need to be, it's very scary. I heard that word over and over. It's scary, but you need to be brave doing this because the healthcare system is broken. And the time is absolutely right for doing this. The status quo is not sustainable. There's lots of federal resources for this. And the science that's needed to get this to happen has gotten much, much better. And I guess I'll leave you just with some links for more information and my email if you have any questions. And I'm happy to answer any questions, Deb.
All right. Thank you very much, Ellen. I think you've given us a great overview of the challenges ahead as I think all state policymakers look at redesigning healthcare systems to get more value. But you've been able to break some of the challenges into doable steps, so that's always appreciated. We do have questions coming in. The first question comes from New Mexico. Since many states provide Medicaid services through a managed care organization, and since access to the actual costs paid by the managed care organization are limited or non-existent, it is very difficult for a state legislature to identify areas of potential savings. Or what recommendations do you have regarding increasing transparency for Medicaid services through NCOs?
It's interesting, we were talking about this earlier. Yes, how much providers are paid is a very controversial question. In some respects, if you're paying through a managed care plan, a lot of states have set up their P4P programs and held the plans responsible for and given them the performance incentives, presumably to give it back to providers who are actually providing the care. I mean, part of the reason that you're paying them is for them to do those things for you. So you can apply you know what you're paying the plan, and then you should be getting really good quality reporting, hopefully outcome reporting on what you're getting for people. So you can hold the plan responsible through a P4P or a shared savings model the same way you would directly with providers. It is an extra layer, but that's one of the things you're paying them to do, frankly.
Okay. You talked a little about that there are more and more sites up that talk about quality care. Are there some particular places you would recommend that policymakers could go to look at how quality differs in their state by providers? In specific states, you can look at Medicare Compare and compare your hospitals, and it's starting to get to physician level as well, and that's on Medicare. If you're in one of the states that is working on an all-payer claims database, that should become more available to you. If you want to look at states that are sort of leaders in doing this, Massachusetts, through their reforms, has done some amazing work, as well as New Hampshire. Actually, they have cost data from an all-payer claims database on what it should cost, which is incredibly useful for providers, but it's also useful for people who are uninsured or people who are in high deductible health plans who are really self-paying for things. They can see what is a reasonable amount. If I call a doctor and I need, a checkup, how much should I pay for that? So those are becoming more available. I'd have to say it's not as available as it needs to be, but I would start with the Medicare Compare and then look to see if your state has an all-payer claims database. If not, you may be able to get that information through the state employee plan. Okay. Another question from a listener is sort of hearkening back to being around in the system a long time and helping me to understand, ask the questioner, the difference between global payments and the old HMO system. And what's
yes.
the safeguard that care isn't rationed, which seemed to be
yes.
the way that HMOs saved money?
That's a great question. Yes, there's two things. One is we've gotten a lot better, and actually the HMO system, we really couldn't pay for quality because we couldn't really measure it the way we can now. So there are hard stops generally in global capitation, and then also the accountable care organizations, the shared savings programs as well, that they don't get a dime unless they hit certain quality targets. Now, defining those quality targets is where, you know, you end up herding cats, and that might actually be a nice term for the processes that I've seen in other states, but it's really important. The other difference is that these are providers who are making the decisions. So you've cut out one level of middlemen. It's not the HMO denying care. It's the provider making decisions about care, and nobody's in a better place than the person sitting looking at the patient to decide what's the best treatment for this person, what's the most efficient. Now, they need to have decision supports. They need to have the best data and information, best practices available to them. Frankly, I think it's scandalous in our country how long it takes for best practices and comparative effectiveness research to get to the practice level to be effective, but we're working on all that. And so I think some of it is just time, and some of it is because it's the decision makers are at the provider level, and it's also because of the quality backstops, I think, that make people a little more comfortable with this kind of change. And honestly, you know, it's not a guarantee that it's not going to be a result in denials of care sometime, but nothing's guaranteed, and the system we have right now is definitely not working.
The last question is, you mentioned both Maine and Vermont, and I know that I'll add in here, I know that those are states you're familiar with because you work out of our CSG East region. But are there other states that you would recommend if policymakers want to go and look at an example state? Where would they go?
Illinois is doing some interesting, very cool stuff in their Medicaid program, as is Alabama, Pennsylvania as well. Oregon is doing some very interesting stuff around wellness, and Rhode Island, I know that's in my area, around wellness programs in their state employee plan. And there was another in my head, but it's gone from my head right now. Oh, Minnesota. Minnesota's done a lot around episodes of care and bundling.
Okay. Thank you very much. Those seem to be the questions that we've received. As I've told you earlier, first, of course, thank you, Ellen, for sharing your knowledge with us. I know this has been a couple of years' work that you all have done at the CSG East region, and we really appreciate you sharing this with our members across the country. So thank you.
Thank you very much. It's I love talking about this.
And those of you on the call, you will be getting an email with a link to the posting of Ellen's slides. Of course, her contact information is there, and you'll be able to listen to the audio again if you wish and pass that on to friends and colleagues who might be interested. The last request I have of you is, if you have a suggestion for a health topic or a speaker that you would like to hear through our health webinar series, please feel free to contact me. You can get to me through the CSG website, Deborah Miller. It's pretty easy to find me in the health policy pages. And let us know what you'd be interested in, because we're committed to providing these services to our members, and we'd like to meet your needs. Thank you very much for joining us today, and we hope to talk to you again soon.